What's going on, guys? Tony here, and I want to answer some of the comments that came in after the video I posted, I think this morning. The video was talking about one-to-one care, continuing to deliver one-to-one care, but in a higher volume manner, and how you can really generate more than 4 units within a 60-minute time frame, still delivering one-to-one care. So Marcy has some really great questions, and I was hoping these questions would come up. I'm going to kind of nitpick, pull out a couple of the questions that she's asking. So one of the things she was saying was that she understands how a model like this could help reduce the negative impact of cancellations. Awesome. If you're providing 1 unit of skilled care to 5 or 6 patients an hour, how are you able to document sufficiently? So here's the thing. First thing we need to understand is, what is sufficient documentation? We need to understand the guidelines. We need to look at the State Practice Act. We need to look at the individual third-party payer requirements for documentation. We need to satisfy those requirements, but there's really no sense in providing more, right? We have to do what we're getting paid to do. And so I can tell you, whether I'm documenting 6 units on 1 patient, or 6 units across 6 patients, or whatever in between, I'm documenting to support the delivery of the service. And when we look at the documentation guidelines, especially Medicare, when you look at what Medicare actually says that they require for documentation, it has to be taken within context of, 1, the published established references that Medicare has put out under CMS 1500, Section 220, and 2, the context around the plan of care. So documentation to support medical necessity on a patient visit that's a 3rd patient visit is a very different expectation than documentation to support medical necessity on a visit that's the 36th visit in a plan of care. Right? So when we're looking at patients that really don't need the level of services delivered to maybe a highly complex, neurologic involvement, cognitive issues, I'm talking about normal community dwelling individuals, patients that are living independently. Maybe they're living with a spouse, they're dressing, bathing, feeding themselves, they're active in the community, they have, fun, recreational time with their grandchildren. These are individuals that are not at the level of complexity that really require a 30, 40, 50 visit plan of care. These are individuals that might be coming to therapy for 1 visit to learn a home exercise program, or 3 visits, or 6 visits, or 8 visits. And so I don't want you or anybody to lump everybody into the same category. Look at the established Medicare guidelines. Look at what Medicare specifically tells us. Look at the example that Medicare gives us for a reassessment, a progress report. The Medicare published guideline for a progress report that has to happen once within 10 visits. Look at it. It is 4 lines of text. It can be done in 3 minutes. A treatment note. Medicare clearly defines the fact that a treatment note is not intended to support medical necessity. A treatment note is to document what was done, document the total number of minutes, document the total number of minutes per one-on-one service, but it's not designed to support medical necessity. So far too many therapists are missing the technical issues. That's why they're seeing denials, because they're not hitting the technical part of what is required with documentation, and then they're spending way too much time on the fluff. I get passionate about this. I'm not I'm not yelling at you, but it does seem like it. So I would tell you that you can absolutely document 6 units of care in a 60-minute time frame. But I'm not saying that goes back to my point. My expectation is 4 units in an hour. That's what I believe should be more than reasonable for any therapist. Going to 6 units on 40 hours a week is crazy to me. I'm comfortable. My sweet spot is about 4.5 to 5 units. But I think a reasonable expectation is 4 units of one-to-one care in a therapy setting for outpatient, primarily outpatient ortho. I think that's a comfortable level of work. That's a comfortable level of productivity. And then there was a little bit more I want to make sure I understand this correctly. If you're spending 10 to 15 minutes one-to-one with a patient, how is that model different from clinics where the therapist is seeing 4 patients at one time, likely with a tech, and is only really getting 10 to 15 minutes per patient? The real difference is the fact that this is the same model, but billed ethically, billed legally, billed the way it's supposed to be billed. And the fact is there's actual genuine benefit to this kind of model, because if my patient comes in and I'm spending my 10 to 15 minutes with patient number 1, I'm spending quality time with that patient. And then that patient is really doing what the whole goal of therapy is. It's taking the information that I've just shown them, taught them, done with them, and then applying that information on their own in a controlled environment, in a setting that allows them to make mistakes and do things wrong and be corrected. Do I get paid Medicare rates to sit and count reps? No. Do I get paid Medicare rates to sit there and bark out commands? No. I get paid, in my case, to assess the current status, to develop at least an acute, this is what we're going to do on this session, and this is what I need to teach you so you can continue to do this on your own, right? And then once I teach you, I want you to go do it. And I need you to go do it, and I need you to practice it. So that's where, yeah, it's pretty much the same model that you see in high volume corporate clinics, but the difference is it's the model being billed correctly. It's the model being billed legally and ethically. And if we're talking Medicare specifically, if I do a single unit visit, I have a smaller impact on the financial threshold. I eliminate the harmful negative decline in reimbursement from MPPR. And for me, for my personality, it just fits what I like to do. I'm not saying every therapist should do this. I'm not saying every therapist will be able to do it. Actually, the amount of one-on-one time is the same. Okay, one of the biggest things I hear from people, this is a really important one. I almost want to share this in a separate video because I think people probably already clicked off. One of the biggest things I hear from people complaining is that with the PT is that they're doing most of the stuff independently for 15 minutes with the therapist doesn't seem sufficient. So here's the thing, right? We need to understand the role of what it is that we do and we deliver. My style of care, I'm a coach, I'm an educator, I can't do it for you, okay? Yeah, it feels good when I rub your back. It feels good when I sit and talk to you. Those are not the things that Medicare is paying me to do. If you, Mrs. Patient, would like me to do those things, this is how much it costs, I'm happy to do it. I think it'd be really, really beneficial for you. But Medicare doesn't pay me to do that. What Medicare pays me to do, and if you look in Section 220, you look at, I think there's 7 things related to rehabilitative therapy that Medicare outlines. It's the evaluation, it's the assessment, it's developing the plan of care, establishing goals related to the functional limitations. Like, Medicare is pretty clearly defined what it is that they're paying for. That is what I deliver as a billable service when I'm billing Medicare for the time that I spend with my patient. If my patient wants to buy the monthly membership to do the other stuff, they're more than welcome to do it. That's not a covered service. If they want to pay me for one-on-one time directly, they're welcome to do it. That's not a covered service. But the actual covered service, it really probably can be done in 10 to 15 minutes. The rest of the stuff is the fluff, the enjoyment that Medicare is not paying for. And what I would say is the difference between when a patient goes to another clinic and complains about feeling ignored, because that's what it is. They're complaining that they feel ignored. Patients in my clinic never feel ignored. Because I might be working with patient A and patient B might be across the gym. Now, we have 2,000 square feet, just to give you some context. It's an open floor plan. We have one exam room. I haven't been in the exam room probably in 3 years, but we do have it. And so when we're working out, when I have a group of 2 or 3 or 4 patients that are coming at the 9 o'clock spot, right? We're socializing, we're having fun. I'm including everybody in the conversation. Just because I'm working with patient A doesn't mean that I've completely ignored patient B, C, and D. I'm not billing for patient B, C, and D, and I'm not providing them direct one-on-one service. I'm providing direct one-on-one service with patient A, but we're still telling jokes, we're still sharing stories, we're still interacting as a group, as a community. I don't know. It's confirmation bias, right? If somebody did feel ignored, I probably have never heard it because maybe they went to another provider. But I can tell you that I hear the same stories that you hear. I get patients that come in and say, I went to that other clinic, they told me what to do, they ignored me the entire time, and it's not like that here. So the best thing that I can say is, based on the patients that have been to both kinds of therapy, even though we have this kind of community group one-on-one hybrid model, the patients have said, I've been to other clinics where I felt ignored, and it's not like that here. So the last question you had, it was in a different comment. You said, especially with the patient's high copay. Let's talk about that, because I think that's super interesting too. Now, of course, Medicare doesn't have a copay, it has a coinsurance, but many of the Medicare beneficiaries have a supplemental plan that will pick up the coinsurance. But what about a Medicare replacement that has a $40 copay, right? And so, of course, there's going to be your price-conscious consumer, and then there's going to be your consumer that just wants the best possible experience, and they're happy to pay $40 a session. $40 a session is a bargain when you look at $250 to $500 sessions if somebody was really paying for direct one-on-one time with me. But that being said, how do we handle a $40 copay? Well, if I know that I'm going to deliver a single unit session, right? And I know that this individual has a $40 copay. What I might do is look at my toolbox, look at the resources that I have available, and determine, based on this person's financial obligations, what's going to be the best plan of care for them. And I usually lay out 2 or 3 options. It's not infrequent that I might evaluate a brand new patient and I might say, look, the reality is, you don't need to come 3 days a week for 4 weeks and pay me $120 a week because of what you're dealing with in your shoulder. Let's do 1 session, billed through insurance. You'll pay the $40 copay. I'll spend the full hour with you. We'll create the entire plan of care. And then you can choose to buy a monthly membership so that you can come in independently. You can go through all of your exercises, or you can just take the information that I've given you over the hour session or the half-hour session or whatever it is that I'm doing and do it on your own. The reality is, again, just like the person that felt ignored, it's a feeling, it's a perception, it's an emotion. When does $40, because you know, based on your other comments, you know that there are patients who are paying $40 a visit and getting 10 minutes with a therapist at other clinics, right? There's a guy, I interviewed him, he's got a YouTube channel, Russ is Right, he's a great guy, super nice. He publicly came out saying that he has spent over $6,000 in copay costs during his recovery from his total knee replacement. $6,000 in copay costs over the course of his rehab program. Yeah, people are spending real money, and it adds up really quick. My question is, can I create the patient care experience that satisfies the goals, the objectives of the patient, that maintains my compliance with third-party payers if I'm contracted with them, and that I believe whatever the price I choose to charge is worth 5 to 10 times the actual dollar price. So if I charge $40 for something, I want it to be worth $400. If I charge $500 for something, I want it to be worth $2,500 to $5,000. Right? That's the only way I feel good. If I sell something for $100 and it's worth $102, I don't feel good about that. I need a 5 to 10x multiple on whatever it is that I'm selling or charging. So the perception that a patient is paying too much and receiving too little is either the therapist doing a bad job and truly selling the value of what it is that they're delivering, or it's the therapist's own perception, which I see this constantly. I'm guilty of it myself, where you're like, oh, I can't charge $40 for 15 minutes. Are you crazy? I've got another video, and I'm not saying you're crazy. I'm talking to myself. I've got another video that I just made public talking about, think of the amount of time, think about the amount of effort, the cost that you've invested in gaining the expertise. Any therapist watching this, if you really calculate down how much it costs per hour to actually be a therapist and deliver the level of service you're delivering, not counting overhead, not counting anything else, I'm finding the average cost is somewhere between $25 at the lowest end, upwards of $50 at the higher end, just to be able to be a therapist, just to be able to see a patient and call yourself a DPT, PT, whatever it is you call yourself. So the fact that a patient we perceive might get upset to spend $40 to spend even 10 minutes with me, that's a problem with the marketing, the communication, my own insecurities as the therapist. That's not too much money. That is not too much money. So lots of great stuff. I'm so thankful that you asked the question. I'm so thankful that we can get this conversation going. I really do. I think we need to have more of these conversations, because the business models that were successful in 1982 are not going to be the business models that are successful in 2022. And the reason why we see so much burnout and we see so much frustration and we see so much agony in the profession is because we just don't ask the right questions. We don't think about this in the right way. We need to look at the problem from different angles so we can come up with a better solution. So as always, thank you so much for being here, for asking me those questions, supporting the channel, and I'll catch you guys on the next video.